Good afternoon, everybody, or good evening to some of our international participants. I really appreciate everybody logging in for this webinar. And my main goal is hopefully by the end, you guys will feel more comfortable with reptile anesthesia and analgesia. There's still a lot of information, obviously, that has to be learned when it comes to the analgesia aspect of reptiles. But the main goal is, go through some information so that at the end, hopefully, people will be a little bit more comfortable. I'm going to show you the outline here real quick. We'll go ahead and start with some definitions. We'll talk about some relevant anatomy of reptiles that is directly applicable to their anesthesia and analgesia. We'll do a brief review of the analgesia of reptiles, and what I'm going to do is concentrate really on the analgesics that have been shown effective in reptiles up to this point. We're not going to talk about the things that are not effective. We're going to focus on the things that are effective. Then we're going to talk about anesthesia, and what my goal there is to specifically talk about some drugs, but more specifically talk about specific protocols and examples of how you can use different analgesic and anesthetic protocols. We'll talk a little bit about monitoring and support. I think that's a really important part of the key and success of proper anesthesia in reptiles, the recovery, and then kind of summarize everything with some keys to success and some things that I think over the years have really changed the way that we do anesthesia in reptiles and improve the chances of success with these patients. So I realize obviously most of those are familiar with the terminology, but in practice we get busy and we kind of throw the sedation, tranquilization, anesthesia terms around kind of interchangeably. And specifically when we're talking about reptiles, I think it's very important we take a step back, review these definitions, because there's a lot of procedures that we can do in a reptile where they can just be tranquilized or sedated. And again, the big difference is that with tranquilization, you're relieving anxiety and basically creating a state of relaxation, but the patient is aware of his surroundings, right? So if you have a reptile that's very stressed out, that's very high strung, that's moving around a lot, and all you need to do is a minimally invasive procedure or just a physical exam, take some radiographs. Sometimes tranquilization is enough. You don't have to anesthetize these reptiles fully to actually be able to accomplish what you need to do with them. Sedation will be more central depression and drowsiness, and in this instance, the patient is unaware of the surroundings. So that's a little bit of a deeper level. And then, of course, we go into the general anesthesia, where you have obviously full animals that are completely unconscious, that are not aware of their surroundings. And the important thing to realize is that with general anesthesia, we do have some analgesia that's going on during that anesthetic event. But once the anesthesia is done, obviously those animals are going to be painful. So that's why the analgesia aspect comes into play, and it's going to be important. So I'll emphasize that aspect of the tranquilization, sedation, and anesthesia. In practicality, there's very few cases when we have to anesthetize animals fully, and that's going to be for major procedures, cilioscopy, surgical procedures. A lot of other things we need to do just tranquilization or sedation. Very often it's not necessary to do a full anesthetic event in these patients. Analgesia, again, is a freedom or absence of pain. And local analgesia is the loss of sensation in a circumscribed, very specific area, whether regional anesthesia is loss of sensation in a larger but limited body area. So when we're doing some particular ring blocks or something like that, we're doing a local analgesia. If you're doing something like an intrathecal procedure that I'll talk about briefly, then you're doing more regional analgesia. And I think these are two things that we sometimes underutilize in reptile medicine that are very important, and it's also something to keep in mind to apply to our reptile patients. So our goals of any anesthetic event is going to be to do a balanced anesthesia. So we want to try to make sure that we're using multiple drugs. We don't want to use these one or two drug combinations, but we want to balance it out, make sure we're minimizing the side effects from these drugs while taking advantage of the positive aspects of these anesthetic agents. And we also want to do preemptive analgesia, right? So we want to make sure that we are starting these animals on analgesics before the procedure as early as possible. And I typically like to start that, if possible, at least 12 to 24 hours. If our patients that are in the clinic already and are staying overnight, start them the day before. Or if it's patients that you see, but they're coming later on for a procedure, you can send them home potentially with meloxicam or some other analgesic of your choice for them to start that at home beforehand. the fact that we still know very little about the analgesia of reptiles and the effectiveness of a lot of these analgesics, it's very important that we try to be preemptive in that. So this is going to facilitate handling and induction, and it's also going to reduce anesthetic requirements when we're spreading out using multiple drugs as opposed to just one or two drugs in our arsenal. So some things that are critical to remember about anesthesia reptiles. The first thing, obviously, they're poikilothermic species, which means that their body temperature is going to be highly dependent on the environmental temperature. And this is directly related to metabolism. And this is very, very important to remember because a reptile that is cold, that is below the optimal temperature, will not metabolize drugs efficiently. And if they're not metabolizing drugs efficiently, that can lead to delayed inductions, delayed anesthesia, or recoveries, or both. So I think this is one of the big things that people sometimes struggle with reptile anesthesia so much. There's so many issues, is the fact that they're not being kept at an appropriate temperature that's going to stimulate their metabolism. So very, very important to have thermal control of them. We'll talk about that towards the end. They do lack an epiglottis, obviously, just like birds. However, they do have a lot more tighter control of that glottis area. So aspiration pneumonia is not as high of a risk as in birds. In birds, that glottis control is a little bit weaker than in reptiles. They can still, however, drown. So one thing to remember about that is when they're recovering, don't put any water in there. And when they're still in that recovery phase, if you put any water, make sure it's nice and shallow so they don't dunk their whole head in there and potentially aspirate and drown. There's a wide range of lung anatomy across the reptile species, and that's another lecture upon itself. Their lungs differ significantly between lizards, chelonians, and snakes. That can play a big role when it comes to aerating these animals, when it comes to which animals potentially gas anesthesia is going to be easy enough to induce them, which is not one of my favorite things to do, but I know a lot of people do that. So that's something to keep in mind and something you really need to study a little bit further as you dwell into the anesthesia of these patients. They also lack a functional diaphragm, so we got to make sure we are careful when we're working with these animals, not put any pressure on their coelomic cavity. Also monitor your pressure of the respiration. Also make sure you don't go above 15-20 millimeters of mercury. So again, that's another important consideration. And then one of the big things, together with the poikilothermic nature, is the fact that they have a 3-chamber heart, although crocodilians have 4 chambers. But regardless, they can do a lot of right to left shunting. And that's very, very important, especially when we're talking about gas anesthesia, because if these animals start shunting from the right side to the left side of the heart, that means that they're not oxygenating their lungs. And if they're not oxygenating their lungs, that means that the gas anesthetic is not being picked up appropriately from the lungs. It's not going to be as effective. And this is one reason why a lot of times people struggle with the anesthesia of reptiles, especially when they're using almost gas anesthesia exclusively, and some of these animals start waking up during the procedure, is because they're shunting. And there's a lot of different reasons for that. When you put them on dorsal recumbency, those organs start pushing against the lungs, and they can actually increase interpulmonary pressure, and that can actually stimulate shunting. But there's other physiologic reasons that we don't understand or cannot control for, and especially in crocodilians, they have a patent foramen of Panizza. There's also a shunt in the descending aorta. So that's something really, really important to keep in mind, that they have this capability for right to left shunting. And that is the reason that I never, ever rely on gas anesthesia in reptiles alone, unless you're doing something for a quick tranquilization or sedation. But especially anything that's going to be a painful procedure or some invasive procedure, don't rely on gas anesthesia alone. And then lastly, the renal portal system. I mean, this is something that people argue back and forth quite a bit. What I will tell you is, if you can give it in the front limbs or the front part of the body, give it there. But if it's not possible, just give it in the back end. There are certainly a lot of species differences when it comes to this. In crocodilians, I have definitely seen a big difference when we inject in the caudal aspect of the body versus a cranial aspect, whether it's IM or intravenously. However, there's other species that we don't see that big of a difference. So I think for some animals, it is going to be a big difference. Others, it will not affect them at all. So this is something that's going to come up with a little bit of practice. So before truly understanding anesthesia of reptiles, I think it's important to keep these anatomical features in mind, especially when we talk about the lungs, when we talk about the right to left shunting at the heart level, the renal portal system. All these factors can influence the anesthesia of these reptiles. So what about pain? And this is, I know, a lot of interest is surrounding about around the analgesia of reptiles. There's a lot of work that has come out of Wisconsin. Dr. Slatke, Dr. Mans over at Wisconsin have done a lot of very good work in this area, and others. And there's a lot of things that we have learned, but still a lot to be learned. And the first thing that I want to make sure, and I, obviously most of the people in this group realize that reptiles do feel pain and are able to do that, but there's this old belief that reptiles are stoic. How do you tell a reptile is painful? And any of us that have worked with reptiles for a while can definitely tell when a reptile is painful. But here's a list of some things to be on the lookout for. These are things you want to look for in the history of the patient when you're talking to the clients. These are things also that you probably want to observe in your clinic and try to see what this animal looks like, what the animal is doing. So there's a long list out there, and there's different behavior books on exotics. There's 2 of them that cover some of these behaviors also. But I think it's important as veterinarians dealing with reptile species that we educate the general public, we educate the clients that indeed reptiles can feel pain, and analgesia certainly needs to be an important part of any anesthetic plan for these patients. So these are just 2 images here. These are patients that we've had at our clinic. And hopefully everybody can appreciate this little leopard gecko here. You can see the hunched posture. You can see the limbs are pulled out away from the body on the table, the back legs pulled backwards, and he's basically trying to lift himself up from that table because he's so painful. And you can see the eyes are kind of closed, the head is down. So hopefully everybody can appreciate that that is a very uncomfortable looking animal, and I would say a very painful animal. That animal ended up having gout as well as a intestinal obstruction. And then on this end here, we have this little box turtle. And you can see she's kind of receded into her shell a little bit. You can see the eyes are a little bit closed. She looks very uncomfortable. Box turtles, behavior-wise, they're typically fairly friendly. A lot of them will come out. They might be shy at first, but after a while, they get used to being in captivity, and they can come out and look around. So behavior-wise, for this particular species, this is fairly unusual, right? Now, if there was an African spur-thigh tortoise or a sulcata tortoise, obviously a lot of those guys do tend to recede into the shell a little bit more. So being familiar with the behavior of individual species is also important to help you figure out, is that a more normal behavior for this animal, yes or no? And could that potentially be an indication that this patient might be uncomfortable or even painful? So, keep that in mind. Always give them the benefit of the doubt, and always aim to use some analgesics when possible. So we'll do a brief drug review. A lot of this is based on the studies that have been done in the past few years, mostly what's coming out of Wisconsin from Dr. Slatke and Mans. And morphine was the first one that came out that kind of revolutionized, right? When these studies came out, everybody was using still butorphanol, and then all of a sudden, these studies started coming out and making us change our mode of thinking into using more the mu agonist drugs as opposed to the kappa agonist. And there's a number of studies in red ear sliders, bearded dragons, crocodilians, anoles, etc., that showed that morphine was probably more adequate for them. The big concern was this respiratory depression, and I've spoken with Dr. Slatke about this quite a bit, and I know he received a lot of feedback from a number of people that were seeing a lot of respiratory depression with morphine, especially when combined as part of an anesthetic protocol. So as a consequence of that, a lot of people have switched over to hydromorphone. We still have a pure mu agonist. There's not as many studies with hydromorphone as there are with morphine, but in practicality, a lot of people are using hydromorphone, and the reason for that is that people tend to see a lot less respiratory depression with hydromorphone as opposed to morphine. Now, it can certainly happen, and I have some patients on hydromorphone that I think I'm seeing that respiratory depression, and I think a little bit too deep, and some of those were using the 1 mg per kg of hydromorphone. So I think that you still can get that, but it's not to the same level that you see with the morphine. So for us, with the hydromorphone, it's kind of our drug of choice, or our opioid of choice, I should say, when it comes to dealing with the reptile analgesia. And again, realizing that the studies are still somewhat limited. If I'm using this as part of a anesthetic protocol, I typically tend to go with a higher dose of the 1 mg per kg. If I'm using it just for analgesic purposes in an animal that's not too painful, that's minimal invasive procedure, I might stay lower in the 0.5 mg per kg. And as far as the frequency, that's something that there's not a lot of information out there, unfortunately. That's something that most of us, I tell you, are doing it maybe every 12 to 24 hours, depending on how the patient is responding. But the one thing you have to be really careful, any more than 12, 24-hour frequency, is look for that depression in the patients, because some of them will get sedated again. Fentanyl is another one that's had some interesting studies also. There's some information in ball pythons and corn snakes from injectable formulation, as well as a patch study that was done by Gamble and ball pythons and skinks, where they did measure some absorption of the drug. This is not something that a lot of people that I know are using constantly, but it's definitely a viable option out there. And yes, BD is bearded dragon, sorry. So this is something that a lot of people are using quite a bit. But again, a lot of people are using hydromorphone quite a bit, but fentanyl not so much. And the hydromorphone we're giving either IM or IV. And then moving on to tramadol, and I'll tell you that in our practice, we don't use tramadol that much. I can tell you other people do use it quite a bit. I think that when you talk to some of the anesthesiologists, at least on the mammal side of things, a lot of them are not big fans of tramadol. So all I can tell you is tell you what's in the literature, some of the information out there. There was definitely some depression in red ear sliders that has been reported, although less than with the morphine. So I think with the tramadol, it's going to be very similar to what we potentially see with the meloxicam, which you have to base this based on your clinical assessment of how those patients are doing. There's a dosages there, 5 to 10 mg per kg. There's a very long, protracted dosing scheme of every 72 hours based on that information. So again, I think it's one of those things where you have to assess your patient. And I think that's the biggest challenge that we have in reptile medicine. Sometimes people want to know, well, how often do I need to be giving this, and try to stay with a particular regime. The important thing when you're dealing with any analgesic, no different than in humans, is you start with a dose, you try to put it out to a certain period, but if you think the animal is painful or they're not responding, then you might have to start redosing or using a combination of analgesics. There's a wide range of species in reptiles. Not every reptile is going to respond the same way to morphine. They're not going to respond the same way to hydromorphone or tramadol. So these are the options that are available out there. This is the information that we have from the research that has been done. As clinicians, we have to then take this information, apply it to our patient, and adjust those dosages and the frequency up or down, depending on what we're observing clinically on these animals. Meloxicam, obviously a very widely used drug. We use a lot of meloxicam in our reptile patients. There's a number of studies out there that have shown, some have shown some potential effects, some have not. A lot of these studies, if you notice, have very lower doses of 0.3, 0.2 mg per kg. We know now from the avian experience and a lot of the other exotics that we're using much higher dosages. So in reptiles, I tend to use more 0.5 mg per kg. And sometimes I actually will start them at 1 mg per kg and then taper that down over the next 2 or 3 days if it's something that was very painful procedure, or something that got, like a turtle that got crushed by a car or something like that. And we certainly don't seem to see the side effects with meloxicam that you see in the mammalian counterparts. The big question is, are we actually getting the benefits and the actual analgesic effects from it? I have certainly seen some patients where we feel that we are getting those effects. A lot of times, eating behavior is one good thing to monitor when you have some omnivorous animals like bearded dragons that eat fairly frequently. Some of those animals will stop eating when you discontinue the meloxicam. You put them back on meloxicam and they seem to start eating again. So that's a very clear indication that that meloxicam might be effective in causing some analgesia and relieving some of the discomfort in those patients. But again, it can still be very challenging, obviously, to assess the true benefit of these drugs. We certainly use meloxicam quite a bit. What we use right now is more a combination of hydromorphone and meloxicam. Again, tramadol, some people are real big fans of it. And if it's working for you, if you seem to see some good effects in your patients, by all means, use it. But again, from the anesthesia experience on the mammalian side and even humans, there's a lot of conflicting information about the effectiveness of tramadol and how good of an analgesic it really is. And again, regional analgesia or anesthesia, there's a really, really good paper and procedure that was done by Mans that talks about intrathecal spinal analgesia that was done in red ear sliders. They compared lidocaine, bupivacaine, and morphine. One important aspect to keep in mind is that these were preservative-free formulations. If you use the traditional formulations that have preservatives in them, the chances of getting side effects and potentially even causing death of your patients is going to be a lot more significant. So that's something to keep in mind. I put the reference there. If you're not familiar with this technique, it's certainly something worth looking up and being familiar with. We have certainly used this technique in a number of patients from different chelonian species, everything from box turtles to alligator snapping turtles to sulcatas. And I can tell you that they did a really, really good job describing that technique. If you read the paper and you have it right with you when you're doing this technique, you're going to be very successful. We have everything from students to interns, residents, and faculty try this technique for the first time, and every single time we have been successful at multiple skills levels to actually get this technique to work really well. We're typically using either lidocaine or bupivacaine. And this is a really, really good procedure if you have to do anything that involves the back end of a chelonian, and in particular anything around the tail. One of the things that I use it for quite a bit is phallus amputations. So when we do amputation of a phallus in a chelonian, I don't typically do general anesthesia anymore. I just do this intrathecal technique. And then the phallus will become very flaccid. It'll come out of the cloaca very easily, very easy to work with them. That's one technique to definitely try a few times. I know in Brazil, they've been using it quite a bit also. I have some colleagues that I know have used it over there. So I put this here because I think it's important, again, to look at some of these novel techniques out there. And you can look up that paper in the Journal of Exotic Pet Medicine and find all the dosage information, technique, etc. So what are the indications for tranquilization, right? We started talking about tranquilization, sedation, anesthesia. We recognize obviously these animals do feel pain and some of the analgesic options that we have. Tranquilization is something that we sometimes use for the restraint of fractious animals. So if you have a monitor that is more of the fractious species that you need to do some radiographs, or you need to do even a physical exam, but they're fractious enough, or even a green iguana, an adult green iguana. If they're fractious enough that you need to calm them down a little bit, but you don't need to have them fully sedated or anesthetized. Sometimes ultrasounds, radiographs, transporting animals that can be very, very stressful for certain animals, especially if you're in a zoo situation. Even venipuncture, if you have a large snake and you're doing intracardiac venipuncture on a snake, sometimes tranquilization is going to be important to try to avoid some of the cardiac tamponade that can occur in those animals. If you're doing potential an FNA, not necessarily an FNA of an organ, but maybe just an external mass or a subcutaneous mass or something like that, and you have a fractious animal, that'd be another big consideration. So again, tranquilization is something that I do quite a bit in a lot of our reptile patients. Sometimes I give them just a little bit enough to calm them down. I try not to do anesthesia again unless we actually have to do a very invasive procedure. And then sedation, some of the same things, but now you're looking at a more minimally invasive procedure where you can also use some local analgesia. If you're doing FNAs, again, don't forget to do maybe a little lidocaine block right on the spot where you're going to be inserting your needle to get the fine needle aspirate. Or you're doing a little minor abscess removal or something like that. Sometimes just sedation with a local analgesia is going to be enough on these animals. And I think that's where, if you can do that local or regional analgesia, you don't need to have some of these animals fully sedated when you're doing minimally invasive procedures. So that's one thing to keep in mind also when you're assessing your patients, to really think hard: is this an animal that I need to have a full anesthesia on, or is this something that I can do under tranquilization or sedation? And again, keeping in mind that analgesia has to be an added part of that, right? When we talk about anesthesia, we're not including analgesia in that. Analgesia and anesthesia are two separate components. They're used together and they should be used together, but you have to do both. You cannot do one or the other. So indications for anesthesia, obviously, if you have a surgery, if you have an endoscopy, especially something that's a cilioscopy. I will also say that if I'm doing a gastroscopy or even a cloacoscopy on some species, you don't necessarily have to do general anesthesia for that. You might be able to do that under sedation on some of these patients. I think for tranquilization, it might be a little bit too stressful sometimes, depending on the patient. But if you have a critical patient that you're concerned about their hydration, might be anemic, and you don't really want to put any more drugs into them, even tranquilization might be enough for that. So again, for gastroscopies, removing some foreign bodies from the stomach or doing cloacoscopies, just sedation might be enough with that in certain circumstances. But if we're doing cilioscopy, if we're going inside the coelomic cavity, for sure you want to anesthetize those patients, or anything that's an invasive procedure like an ultrasound guided biopsy, or anything that's going to be really more involved where you really need to make sure that patient is not moving around. But again, you can see a lot of indications, a lot of things that we can do with reptiles can be done under sedation, and you don't always need that full-blown general anesthesia. There's a long list of injectable agents out there, and most of you are familiar with this, and I think even some of our international colleagues here have access to a number of these. These are some of the more common ones that people are using. Ketamine and dexmedetomidine obviously has been a classic combination for a long time. Midazolam is one that I really, really like. Benzodiazepines have a very, very wide margin of safety. That's one of the reasons I like them so much. It is going to be very difficult to overdose a patient with a benzodiazepine like midazolam to actually have adverse effects. Now, when you're using midazolam, you have to be careful because it's very high dosages reported out there, and typically we're using midazolam no more than about 1 mg per kg, anywhere from half a mg to 1 mg per kg. You can use it at much higher dosages, and the downside with that is that a lot of those patients will take a long time to recover, especially if it's a patient that's not warm enough, that it has a slower metabolism, they're not metabolizing the drugs as efficiently. Midazolam can certainly cause a prolonged recovery from anesthesia in some of these patients. You can always reverse it, but the reversal has been very expensive over the years. It's come down in price recently. But midazolam typically, again, half a mg per kg to 1 mg per kg. And sometimes I'll use midazolam by itself if I have some patients that just need tranquilization or sedation. Midazolam can help you achieve that. Propofol obviously been widely used, also fairly effective, or very effective in a lot of reptile species also. Since it's come down in price over the years, it's also a lot easier to do that. And then the newest one that's been around in the market for a little bit now, at least in the United States, other parts of the world, it's been available for quite a bit of time now. But here in the United States, the alfaxalone has become available. Still somewhat expensive, but there's certain circumstances where alfaxalone is going to be your drug of choice. And those of you that may not be familiar with alfaxalone, alfaxalone is a neuroactive steroid agent. It causes very rapid induction and recovery in reptiles. Just with alfaxalone by itself, you typically get 30 to 45 minutes of either sedation or full anesthesia, depending on the dosing. It can be given either intravenously or intramuscularly. So that's one advantage over propofol, is that you can actually give alfaxalone intramuscularly, and you actually get just as good effects sometimes as you get intravenous route. The doses that are reported, and there's a number of papers out there, but most of the dosages are 5 to 10 mg per kg. You can use it as a constant raised infusion also, or give it as a bolus. And it seems to create minimal cardiorespiratory depression as opposed to propofol, but it is also dose and rate dependent. So you do have to be careful with the alfaxalone, although people talk about giving a bolus. The alfaxalone can cause respiratory depression if you give it too quickly, especially if you're giving it IV. It just doesn't seem to have as long-lasting effects as the propofol does in the respiratory depression component. I can tell you that we've been using alfaxalone for a number of research studies here recently, and there seems to be quite a bit of species variability on the dosage. We just did some Louisiana pine snakes, which is a fairly rare species here in our state, and it actually took us 30 milligrams per kilogram to be able to have effective anesthesia in those animals with alfaxalone. We're doing a combination of hydromorphone and alfaxalone in those animals to implant some radiotransmitters. So the starting dose most of the time is 5 to 10 mg per kg, and in a lot of species, people get good results with that. But we have seen a number of other species that take much, much higher dosages. Again, fairly newer drug here in the United States and other parts of the world. Very effective, seems to be fairly safe. Even at very, very high doses in reptiles, it seems to have a fairly wide margin of safety. In dogs and cats, not so much. Once you start getting the 40, 50 mg per kg in dogs and cats, you start running into issues with those. So I mentioned the expense of alfaxalone. The one instance that we found that alfaxalone seems to be a much better alternative is when you have these big sulcata tortoises that come in that are all close in the shell, that you definitely have to get them out and do an exam because they have to be examined. They have something that needs to be addressed. In the past, those were very, very challenging cases, and we use a combination of midazolam, ketamine, dexmedetomidine, and that seemed to be fairly erratic in those patients. And by the time you add the cost of all those medications, you're spending just as much, if not more, than the alfaxalone. So I think that is one big consideration. We have some bigger reptiles that are difficult to have access to, especially intravenous access. Alfaxalone should be a good consideration. And again, if you're using at the lower dosages, you're going to get most of the time at least a sedation effect. And as you increase the dose, you can get an actual anesthesia by itself. Of course, this is not balanced anesthesia, so this is not necessarily something that I would recommend for surgical procedures to use alfaxalone by itself. You want to combine it at least with an analgesic, something like hydromorphone or morphine. And most of the instances that we've used it by itself has been in research situation, not necessarily client on patients. So, while the cost is high, by the time you add up the cost of all the other drugs together and the volumes, alfaxalone sometimes comes fairly comparable cost-wise to some of the other medications and some of the other combinations. And the cost of alfaxalone has come down a little bit also since it was back on the market, but it's still rather expensive. So inhalation agents, obviously everybody's familiar with this. There's a number of studies out there that have been done with isoflurane. You have isoflurane and sevoflurane as the main two. And then as we come back down here, I want to point that what we're talking about here is a minimum anesthetic concentration. Reptiles do not have any alveoli, they have faveoli instead. But in the mammalian literature, this would be the MAC is really referred to as a minimum alveolar concentration. Here we're talking about minimum anesthetic concentration. So we're going to talk about MAC. It really is not exactly translate the same as in mammals. The other thing to keep in mind about the MAC studies is that these MAC studies are done when you're using the gas anesthetic agent by itself, right? So when you're adding some other injectable agents in addition to the inhalant agent, that means that you can actually decrease the concentration of your inhalant agent. And that's something really important to keep in mind. Anytime you're planning an anesthetic event in reptiles, you have to figure out, okay, what's my full protocol? And when you're going to the literature, keep in mind that each of those studies is done looking at that drug individually. When you start using multiple drug combinations, when you start using anesthetics together with injectable drugs, and when you're using what in essence is balanced anesthesia, by using multiple drugs, you can actually decrease the concentration of each drug or the dosage of each drug. And what that does is you still get some good effects from a wide range of anesthetic drugs you're using, but you're minimizing your side effects. And that, I think, is something that also makes a big difference in the success and the key of anesthesia in reptile patients, is that we need to start using a broad range of different drugs, more balanced anesthesia, to minimize the side effects of some of these drugs, and especially with ketamine. Ketamine is one that there's some really, really high dosages out there. And we use ketamine, but I never use ketamine more than maybe 3 to 5 mg per kg because we're using it in combination with a lot of other drugs. When you start getting into the 20, 30 mg per kg of ketamine, those are a lot of the patients that sometimes have a hard time metabolizing that much ketamine because they're not warm enough, they're dehydrated, etc. And then you start running into a lot of the side effects. There's also sevoflurane. Some people are real big fans of sevoflurane. We still use a lot of isoflurane almost exclusively because of the cost. There are certainly some papers out there that have shown some differences in induction and recovery, but clinically, again, a lot of these times and differences are not that significant. And again, I'm not a big fan of using just inhalant agents as the sole source of anesthesia for reptiles because they have that right to left shunting that happens in the cardiac region. So again, if you're not sending blood to your lungs, your anesthetic agent, gas anesthetic agents are not going to get picked up from the lungs, and you're not going to have the effect that you should have from those agents. So that's something really, really important to keep in mind. If you have a lizard or a snake that you need to just tranquilize or sedate briefly, yeah, sometimes you can do an inhalant agent by itself, and that's going to be fine. But I think if you really need anesthesia, you should be using a combination of injectable agents. You should not be using inhalant agents as your induction method or your sole anesthetic method. You need to really stick to using a balanced anesthesia involving both injectables plus or minus also some inhalant agents together with that. So those of you that have a preference for sevoflurane or isoflurane, that's fine. I think a lot of this boils to your personal preference and experience. But on the cost difference, isoflurane still works really well in those patients. So we're going to run to some of the different protocols. In mammals, we're used to talking about pre-medication, induction, and maintenance. In our field, we sometimes kind of pre-medicate and induce at the same time. We don't split them quite as much. But for pre-medication, you can give a combination of ketamine, dexmedetomidine, midazolam. You can use propofol or faxolone. I included hydromorphone or morphine here because although they're the true analgesics, they also do provide some sedation in these patients. And again, with the hydromorphone, you have to be careful as you go on the higher end of the dosing. You will see some of these reptiles that will be a little bit more depressed, not necessarily just respiratory depression, but they're going to be more sedate than some of these animals that tend to have a little bit of a longer recovery potentially. Again, quite a combination of drugs out there. I'm not saying you use all of this together, but you can combine all of this in different ways, and we'll go over some specific examples here shortly. And then for induction, typically you're talking about propofol or faxolone. Those are going to be your true induction agents, just like in the mammalian counterparts where you put an IV catheter. In this case, you just go in and inject straight IV with the propofol, or with the alfaxolone. Again, the advantage being that you can do that IM. You don't have to go intravenously all the time. And then your maintenance is going to be with isoflurane or sevoflurane if you have the gas anesthetics available. Or again, with the alfaxolone, you can do even a CRI of alfaxolone. That is not something that I have any experience with, but there's some information out there, some papers on that. So you potentially could do CRIs of alfaxolone and maintain them on that. But again, realizing when you're using a single agent alone, you're going to have to use much higher doses. That means that your chances of side effects are going to be higher. So you want to try to balance on your anesthesia, use multiple agents to decrease your issues. And you can do that the same thing, obviously, with the propofol for a CRI. So I want to go over some examples. It's just some things, and these are actually, real cases that we've had and some of the options that we had to go through over the years and things that have worked. So I talked briefly about this already. You have one of those big sulcatas that comes in. Let's say you have a 30, 40 kilo or more sulcata that comes in for a physical exam. It's one that has been very depressed at home, not eating, not doing well. So you need to get a complete blood count on a chemistry panel. So you really need to get this animal out of the shell, be able to get access to the limbs or the head so you can get blood and you start assessing what's going on. So there's two options that you have. Typically, you're going to just need to tranquilize or sedate this animal so you can do your exam and get your blood. Your goal is not to anesthetize these animals, it's simply to sedate them or tranquilize them. So one option is to use midazolam and ketamine plus or minus dexmedetomidine. If you use all of these at very low dosages, okay, and you give that IM, you're going to get just a tranquilization or sedation, not necessarily get a full anesthesia, especially in a big sulcata like this, okay? If you can get IV access, that's better, but obviously here, part of the reason we're doing this is that we need to get blood for venipuncture, and this animal is not being cooperative with us. So what happens a lot of times is we have these animals that are clamped in. You're trying to access a very hard, scaly area in front of those limbs and try to access the muscle layer. But a lot of times what I find is that the absorption is not very even, and you get very erratic effects of some of these drugs, okay? Then the option B, like I mentioned already briefly, is alfaxolone. And we've had a lot of these sulcatas over the year that we kind of did this combination, and some of them we got some really good results, some of them we didn't, and we kept dosing and dosing and overdosing. And some of the times we have some of these animals that eventually became tranquilized or sedated, but then they re-narcotize on you. And finally, they start absorbing all these drugs, and some of these animals take a really, really long time to recover. They never go into a full anesthetic event, but they stay sedated for a very long time, and it takes a while for them to recover. So that's definitely a challenge in those big sulcatas, and something that we struggle with over the years. And now what we do is we go straight for alfaxolone. And again, by the time you might add the cost of all these drugs, especially if you have to redose them multiple times, and compared with the alfaxolone, it actually is not that big of a price difference. So anytime we have a sulcata now, we talk to the clients right away. If it's something that we have to get that animal out to be able to do an exam, get some blood work, we explain to them what the cost is going to be to do that. And we go straight for the alfaxolone. We think it's better for the animal. It's a lot easier to get that to have effects a little bit faster. We have done it for some animals that needed that had cloacal prolapses, for example. We had one with a prolapse here recently that we just needed to be able to get the tail out enough to examine the prolapse and assess what was going on. And alfaxolone worked really well for that. That animal was tranquilized with the alfaxolone. It wasn't fully sedated. We used one of the lower dosages, about 5 mg per kg, and we were able to at least examine the tail, assess what was going on with that prolapse. And it was one that thankfully just had to be repositioned. The tissue had to be put back into the cloaca. It was not necrotic yet. We put a purse string, and then the animal did well after that. And that was all done with alfaxolone, lowered end of the dose with a tranquilization, and allowed us to do that. So again, very effective drug. Two different ways of doing this. If you have alfaxolone available, I highly recommend you use it in these cases and consider it. What you'll find is going to be a little bit more consistent in the effects that you get with these animals. Second example will be an esophagostomy tube. These are mostly done in chelonians, but it can be done in a lizard also. So typically you can do midazolam, IV or IM to get some sedation on those animals. You can use hydromorphine or morphine, IM, or even IV also for analgesic purposes. I typically also add meloxicam to these animals. And then I do a local lidocaine block. So at the point where I'm going to be inserted in that esophagostomy tube, I will do a lidocaine block or a lidocaine bleb in that area to try to minimize the pain effect as much as possible. Okay. Now you can alfaxolone for this also. It's just that typically most of these animals, the alfaxolone cost is going to be much, much higher because you're not having to redose them. And a lot of times these esophagostomy tubes, I'm actually doing more of a sedation on these animals. I'm not trying to reach full anesthesia to put an esophagostomy tube. I have even done some of this just with the animal tranquilized. I have animals that were very depressed, that were anemic, that were hypothermic. We warm them up first, obviously try to bring them to temperature, get their metabolism back where it should be. But esophagostomy tubes are something where you can take advantage of using analgesics, a combination of opioids and non-steroidals, as well as a local. So you have here three different analgesic approaches. We have an opioid, a non-steroidal, and a local analgesic, together with a sedative or a tranquilizer, and you're really trying to make sure that you maximize the chances of you providing analgesia and pain relief to this animal. But for an esophagostomy, you don't have to knock those animals down. Okay, very, very often you can do them with a tranquilization or a sedation. And then a third example will be something now more involved. If you have, For example, we recently had some alligator snapping turtles that we had to do radiographs, gastroscopy, plus or minus cilioscopy, depending on what we saw. We have one particular animal that has swallowed some foreign bodies, and we weren't quite sure what all we're all gonna end up need to be doing. It's gonna be more involved procedure. Alligator snapping turtles are also more aggressive species, so you want to make sure that you have these animals well restrained and well under control. So in these cases, this is what we did, and this is an actual case, actual dosages. So we gave hydromorphone 1 mg per kg. Ketamine, I always start about 2 or 3 mg per kg. I never go higher than 5. Dexmedetomidine, I typically start at the higher end, 0.5 mg per kg. And then midazolam, I typically start on the 1 mg per kg also. I'm very comfortable with midazolam. It's a drug that I've used quite a bit over the years, so I've become rather comfortable with it. And then I typically like to give this all as an IV injection. So this is a protocol that I've really been using in reptiles a lot lately. It's a combination of the hydro, ketamine, dexmedetomidine, midazolam. Now, I'm using all these, especially at very lower dosages, especially the ketamine and the dexmedetomidine. We're using it at much lower dosages that's described other for reptiles. But because we're using balanced anesthesia, we're combining multiple anesthetic agents. We're combining an opioid analgesic there also, and we're giving it intravenously. If you can get these drugs intravenously, you typically get very consistent, very smooth inductions. And in these alligator snapping turtles, it's interesting to know we started some of these animals, we started working with them and giving these injections in the subcarapacial sinus cranially at the base of the neck. And we were getting very, very erratic events, anesthetic events in those patients. And then we moved on in the dorsal tail. So we injected into the dorsal tail vein or the dorsal tail sinus. And even though we were on the back end of the animal, all these guys actually did very, very well. And they actually responded from the back end, from the tail quite a bit. They were very, very consistently going down immediately. Sorry, yeah, somebody asked about, this is a typo here, that should be 0.05, so 50 micrograms, correct. So with dexmedetomidine in reptiles, is described typically 50 to 100 micrograms per kilogram. So we typically start with about 50 micrograms and then go from there. And the 50 to 100 micrograms, not milligrams, but micrograms, 50 micrograms to 100 micrograms, that actually is very effective in reptiles, very well described. So that's pretty standard in reptile medicine. And then maintenance on those animals, once they get intubated, you put them on isoflurane. So again, this is a combo. I've used this combination in alligators. I've used it in lizards. I've used it in different chelonian species. I've used it in snakes. Snakes were typically given in IM. Typically, IV access in snakes is a lot tougher, but that has worked really, really well in those species. So again, using lower doses of all those. And then this it's a different approach to the same case, where you could also do hydromorphone for analgesia, and then you could do a propofol or alfaxalone induction, and then maintain them on isoflurane. But again, the downside of this is that you don't have that balanced anesthesia as much as you did in the previous protocol. With the alfaxalone, you're going to get a good 30, 45-minute effect. And the reason I chose the higher dose of alfaxalone here is, again, because we're not adding anything else other than the hydromorphone. We're not adding dexmedetomidine, ketamine, or anything else. So if I'm going to use it by itself, I typically go a little bit higher in the dosages. And then another example would be a green iguana for coelomic surgery. And again, very similar to the protocol in the snapping turtle. Again, hydromorphone, ketamine, dexmedetomidine, midazolam, give all those IV, and then maintain them on isoflurane. All these cases, I should mention also that we typically are also keeping these animals on meloxicam afterwards. And again, the data on the effectiveness of meloxicam in some species, it seems to be better than others, but we definitely use it. Always better to err on the side of error and think that you hope that it's working and that it's going to provide some analgesia rather than not give it at all. So there's a long list of injection sites. This is obviously going to vary with the species quite a bit. The one thing that I'm finding more and more is this subcarapacial sinus in the chelonians. You have to be really, really careful. Sometimes we're seeing very erratic absorption from this site, especially in really large chelonians that maybe are not quite up to temperature. Their metabolism is not quite as active as it should be. And we have seen a lot of problems with re-narcotization even. And those alligator snapping turtles, we worked with a large group of them here recently, and we have some of those animals that actually seem to recover quite well, and then they would go down again, and they look like they were re-narcotizing again. And I had one in particular that we couldn't figure out what was going on. All the vital signs were stable, but the animal was really down and just kind of depressed and sedated. And I went back into the sinus, and this was probably about an hour after the procedure was gone. I went back to the subcarapacial sinus, and I was actually able to pull propofol out of that sinus. That animal had gotten propofol, and I actually pulled propofol out of the sinus. I got back about a third of the volume that we had put in there originally. And as soon as we did that and hydrated him better, the animal started recovering. So I think that animal essentially has his own little CRI, if you will, there in that sinus where it was not being reabsorbed properly. And it was just basically slowly leaking out of the sinus. So that's a big word of caution with that subcarapacial sinus in the chelonians. We have seen some erratic anesthesia inductions and even some prolonged anesthetic events with that site. So just be careful with that. Injection sites, here's an alligator snapping turtle. One thing to keep in mind is a lot of the aquatic chelonian species have not only a ventral coccygeal or a ventral tail vein, but also have a dorsal, and some of them even have two laterals. So some of the species have actually 4 tail veins, dorsal, ventral, and a lateral one. Alligator snapping turtles have a really nice one here at the base of the tail, and we have done a lot of anesthesias in alligator snapping turtles at that site, and it works really, really well. It doesn't seem to have any issues with having any delayed inductions or anything like that, so that's a really accessible site. Also very far away from their mouth, which they can be pretty aggressive in these animals. So that's something to keep in mind, especially with aquatic species, particularly freshwater chelonians. Here's some of the subcarapacial sinuses. Again, very common site to get blood, also give injections. Here's a little box turtle. We have used the cap of a syringe case to basically push the head in to try to protect your fingers, and you can go right on midline where the skin meets the shell, and that's a good site there. Here's a gopher tortoise getting propofol in that sinus, and again, something to be really careful with that sinus, because when you have a volume that big, that sinus will not accommodate all that volume in there. So I think in a lot of cases we're getting a lot of leakage out of that sinus, and we're having some of these animals that have delayed recoveries because the propofol is not being absorbed efficiently. And then in the tortoises or the land chelonians, one that works really well is the brachial plexus. So this is cranial here, this is caudal. This needle is not fully placed inside, but you can see this tendon ligament here. So that's typically going to be your landmark. Basically, there's a big sinus that lays right about here. So let me see if I can get fancy with the pointer, but there's a bloody sinus right about here on this area on that leg. And typically your landmark is you're going to come in right above this tendon ligament, and you're going to insert right about this angle, aiming towards the elbow joint a little bit. So the elbow joint will be right about here. So you come in sort of at this angle like that. Okay. You want to be careful you're not hitting the joint. Obviously, you don't want to get any joint fluid back. But that's a really nice site. In sulcatas, gopher tortoises, any of the true terrestrial chelonians, that site works really well. Some of the aquatic species that you can get blood from there also, it just doesn't seem to be as prominent as it is in the terrestrial chelonians. And then the jugular in the chelonians obviously is another site. It's a blind stick. Some of them it really shows really well. Some of them it does not. This is a red ear slider here, and it's just showing basically you have the tympanic membrane right here. Let me see if I can outline that for you guys again. So here's your tympanic membrane, okay, just to give you some landmarks. And then the skull ends right about here, okay? So that's where the skull ends. So that's typically the landmark that I use to insert my needle. I palpate where the skull is, and I go right behind the skull, caudal to where the tympanic membrane is, and go in that direction. Now, the challenge with chelonians is that some of them have a single jugular, but some of them, their jugular will do this, and then I'll split into a dorsal branch, and then it'll split into a ventral branch. And this varies quite a bit with the chelonian species. Some of the sliders have a lot of this split into a dorsal and a ventral branch. Some of them it doesn't. So it's a lot of variability. This is a site, though, that you can put intravenous catheters into that jugular if it's one that you can see fairly easily. And sometimes we have done that for an aesthetic event in some of our patients. So it's something that you can keep in mind. But again, jugular being a very common site also for getting blood and venipuncture and aesthetic events. Ventral tail vein in a bearded dragon, this just shows the positioning. You're going to be right on midline with this, and that's important. Now, keep in mind, you see the difference. Here's the vent. So look at the difference of the distance in those animals. The reason we're a lot further away from the vent in this animal is because this is a male here. So you got to be careful with the hemipins. The hemipins are going to live on either side of the tail like that. So you want to make sure you're not puncturing the hemipins. Whether this right here is a female, this very small femoral pores as opposed to the large femoral pores here. So in the females, you can get a lot closer to that vent, and you're not going to have any issues or concerns about the hemipins. Jugulars and lizards, you use that scale on the iguanas right here, and then go to the point of the shoulder right here, and that you're lays somewhere in a line there. That's kind of the landmarks. And then in this bearded dragon, and I don't know if you can appreciate, they have this little protuberance, and I don't know the scientific term. I always tell my students that's the nubbin, and I said that's the scientific term for it. Well, they have this little protuberance on the side of the neck, and that's a really, really good landmark to go in and do the venipuncture on these patients. Typically, if you go right ventral to that little protuberance, that jugular lays right underneath it. And in adult bearded dragons, that actually can be a very, very successful venipuncture. This image here at the bottom is actually from a lab that we do for our vet students, and almost all of them can usually hit that jugular fairly easily, and again, using that little protuberance as a landmark. So the key on that is actually to stay ventral to that protuberance, and that jugular typically runs in a line right about here. Very short neck, obviously, so it's a little bit of a challenging site, but that actually can work quite well in those patients. And then a favorite of the students is typically the ventral abdominal. So the head is to the right, cranial to the right, tail to the left. I don't know if you all can appreciate, look at the scale pattern here. And then when you get to this point, you see how these scales start getting a little bit tighter right there. And you see that the scale pattern changes a little bit. That is the umbilical scar. So that's basically where the remnant of the yolk sac used to attach. And that is a very important landmark, because what happens is you have the ventral abdominal vein that's running right on midline, but right at the umbilical scar, that vein does this right here and it splits. And basically where it splits, you have this Y, and this is the wider part, the widest spot where that vessel is. So if you go right in that umbilical scar, you're typically hitting the larger part of that vessel, so it's a lot easier to get blood from the patients. And here's showing that again, that umbilical, that's the same animal, that umbilical scar was right there. And you're gonna go right parallel with the body. That vessel is sitting right underneath the skin right here in that surface. And when you're going is you're going right at the split of the Y. So if you go right in that umbilical scar, you're going right at the split where that vessel will split into the right and the left branches. Some people are really good at this side. It is my least favorite side. I have a lot of hard time getting this side, but vet students are very, very good at it. And I've actually had students and interns and residents that are able to put intravenous catheters in this site also intraoperatively for anesthesia. So again, it's all about your preferences, about the things that work best for you. And then a snake, this is a head to the right, tail to the left. And again, this is a midline on a snake. So those that have really, really good long tails, you can sometimes get that vessel, get the ventral tail vein. Otherwise, the cardiac puncture is a preferred site also. You want to be careful that that animal is not moving a lot with the cardiac puncture. And then the one that people forget is a palatine vessel. So right here, this dark surface, that's actually a palatine vessel. You can barely see it on the other side. In snakes, that is a normal asymmetry. So snakes typically have one side that's larger than the other. You can actually get blood from that vessel. You can actually catheterize that vessel. You want to make sure also that it's not something that is a venomous species. But we've had actually some real big reticulated pythons that we put some 24, 26 gauge catheters in that vessel intra-op and been able to give fluids that way. So that's another option. So intubation, I'm just going to show some pictures real quick. In chelonians, you can see that glottis sits right at the base of the tongue, and you can see that endotracheal tube in there. Remember that chelonians and crocodilians have complete tracheal rings, so the C's go together. Chelonians and crocodilians, the rings are complete. And then your squamates, which are your lizards and snakes, are incomplete. There's a snake right there. You can see the opening of the glottis. The tongue is going to be right here. And then the one trick that's important, and you'll see it here, stabilizing that endotracheal tube so you don't get a lot of movement in there, a lot of rubbing against the trachea. Here's a spatula that's been used for that purpose, but you can use also tongue depressors. Here's a green iguana. And again, the green iguana can be really tough. This is a tiny little patient, so we're using actually an IV catheter. So we're using the catheter itself as the endotracheal tube. The challenge is that this will bend, okay? So you have to make sure that you stabilize that catheter that you're using as an endotracheal tube. Otherwise, you can actually occlude that tube and you can run into a lot of problems. So here's that same iguana, and this is what we typically do. We put a tongue depressor over the neck of the animal. We tape it all together. So this whole area is now one structure. That neck, that endotracheal tube, and that anesthesia circuit is all moving as a single unit. And that avoids the issues with that endotracheal tube getting kinked, getting obstructed, and you're losing your patient because you're actually not ventilating them when you thought you were. So that's something really, really important to keep in mind with these tubes. And then I put some crocodilians pictures here. They do quite a bit of crocodilian work. I'm not sure how many do crocodilians out there, but obviously keep in mind you want to have some sort of speculum in there, a PVC pipe or some sort of block. And then it shows you have to go, there's this gular fold here, an extension of the hyoid apparatus at the base of the tongue. So you have to fleet that backwards to then gain access to the glottis, but they're fairly easy to intubate most of the time. As far as patient monitoring, once you have the patient anesthetized or intubated, a corneal reflex is a really, really good indicator of depth. It's also a good indicator of death. Now, the challenge is that a lot of these reptiles, when they're really on deep anesthesia, you lose that corneal reflex. But you want to make sure that when you start recovering them back up, that corneal reflex is one of the things you want to start seeing coming back up again. In the snakes, for example, they go in the induction, they get induced from cranial to caudally, and they return the opposite direction. Some of the lizards, it varies quite a bit, and chelonians also. But the corneal reflex is something that you really want to monitor closely. Dopplers, ECGs, ultrasound, and I'll show you in a second why I put ultrasound here to monitor the heart rate. But that's again a situation if you're in the field, sometimes you don't have some of these other tools. But if you have an ultrasound, you can just put the ultrasound probe on the animal, actually visually see the heart, get heart rate that way, monitor the beating heart itself. So you sometimes have to get creative in that aspect. Respiratory monitoring, like everything else, obviously make sure that pop-up valve is open. 2 to 4 breaths per minute is typically enough for these animals. And this is a big, big take-home message right here. And this is, I think, one of the biggest keys to successful anesthesia in reptiles. You have to keep them warm. You have to keep them warm before, during, and after the procedure. You have to keep them at a steady temperature. And in order to do that, you have to be able to monitor their temperature at all times. If you cannot do that, it's going to be a big challenge. Oh, I apologize for my colleagues on the Celsius scale. I should have done that on Celsius. My apologies. Oh, hey, Frank. So Frank here had included 32 to 35 Celsius. So, again, real key element in anesthesia reptiles, you have to keep these animals warm. When they're warm, they metabolize drugs appropriately. They can actually get those drugs to go through the livers and the kidneys and get rid of those drugs out of their system, and they actually will wake up a lot faster. When they're cold, they're going to do at a very, very slow rate, which means they're going to take them a lot longer to wake up from that anesthetic event. So here's just two kind of extreme monitoring examples. Here's a little bearded dragon, a little juvenile. You can see that Doppler probe is bigger than his almost. And here's a sea turtle. This is in Mexico a few years back. And we didn't have a Doppler or an ECG, but we had access to an ultrasound machine, and that worked really well to monitor this animal. We placed the ultrasound probe and look at the heart straight. We were able to get a heart rate. We were able to look at the contractility of the heart, make sure that it was staying consistent. So that actually worked really, really well. Fluid therapy is something else that's very, very important. People forget about this all the time. If you're anesthetizing, not so much tranquilization or sedation, but if you're anesthetizing a reptile, you have to make sure you're giving these animals fluids. You have to make sure they're well hydrated. When you give them fluids, you are ensuring that they actually, again, have proper perfusion. They are perfusing their kidneys or perfusing their liver. If they have good perfusion, if they're warm at the proper temperature and their metabolism is working properly, you can get them to burn through these drugs and metabolize the drugs. If you don't do that, then it becomes very, very difficult, and that's a big part of also the prolonged recoveries in a lot of these patients. In the absence of IV catheter, you can use the IO catheter, intraosseous catheters. We do this a lot in reptiles. This is something that we really, really do quite a bit in our practice. You can do femur, you can do tibia, you can do carapace or plastron. In some situations, you can even do humerus. There's a good paper by Dr. Jill Hitley that came back a few years ago on desert tortoises. They actually compared 3 different sites on desert tortoises doing IO catheters and looked at the absorption. And if my memory serves me right, I believe it was the femur, then the humerus, and then the plastron in order from the best to the least absorption. So there's a lot of, there's some data out there to support that this does work quite well. So you do have to realize, obviously, that the medullary cavity is a solid structure. It's not going to expand like a vessel. So you do have to go a little bit slower. That's going to depend on the size of the patient. It's going to depend on the drugs that you're giving that you have to monitor. There's no specific guidelines out there for that. But it's something that we use quite frequently on reptiles, and it works really well. Here's a little green iguana, just showing some examples. This one is in the femur. Coming in, you can typically bandage the leg at that angle. They typically are able to still ambulate fairly well. They typically tolerate that fairly well. Here's a little tortoise that was actually getting a blood transfusion, and this catheter is actually in the plastron here, and that animal was receiving a blood transfusion. And here's a red ear slider demonstrating the placement into the humerus. The big challenge with putting these IO catheters is you have to be familiar with the anatomy of these animals and the bones. In some of these sliders, for example, the humerus will have kind of this shape, and then it'll kind of angle down, and then it'll come back up again almost like an S. So you have to make sure of the angle that you're going in with that catheter so you don't end up coming through the opposite cortex. Because sometimes what happens is you might come in here, but you actually go through the medullary cavity. Let me see if I can draw the other side. So if that's the bone right there, what sometimes happens is you go in with your needle, but you come out on the other side of the bone. Okay, so you have to be familiar with the anatomy. If it's a species you have not worked with before, I like to take radiographs of that leg if I can beforehand to look at the angle of that bone, and that way I know what the proper angle to place that is going to be. Temperature support, again, really important, and we're gonna just maximize this here. We're showing you a table, different ways of doing this. Very important. Us are taught that conductive losses is the main way that animals lose heat. The big thing to remember is that when we're working with exotic species, in particular small species, they have a very high surface area to body size ratio, volume ratio. So that means they lose heat very quickly, a lot faster than the larger species. So convection is actually going to be the most important way that our exotic species will lose heat is via convection, and that's the air exchange that's happening at the body surface. Radiation losses are very important, especially things like chelonians. Reptiles are either heliotherms or they're thigmotherms. So heliotherm reptiles absorb heat from radiant sources like the sun, okay? And then thigmotherms absorb heat from surfaces like rocks and ground surfaces and things like that. So chelonians, for example, have the highest surface area is going to be the carapace, right? It's going to be in the dorsal aspect. So if you put a chelonian on a heating pad, that's really not going to be a very effective way to heat that animal at all. You want to make sure you're providing some radiation or convection methods to try to minimize heat loss in those animals. So this table really illustrates the different methods that you have to heat animals and the different heat losses they can counteract. All the forced air warmers, things like bear huggers and other equipment similar of that nature, they can counteract both convection, conduction, and radiation depending on the different type blankets that you use with them. Heating pads are typically only good for conduction. Heat lamps only do radiation, right? So what we have done and what has made a huge difference in our practice is we always have a heating pad, but we also have a forced air warmer. And ever since we started using a combination of both, we really are very successful in maintaining these reptiles warm during the procedure. Typically before the surgery, they're going to be in an incubator. We bring them up to temperature. During the procedure, they're going to have forced air warmer. They're going to have a heating pad. And then after the procedure, they go back to the incubator. So we're keeping those animals at the same steady level temperature through the whole ante, peri, and post-operative period. And that, I think, is a big, big key to the success of anesthesia in these patients. And that thing makes a big difference. Since we started doing that, our patients wake up much, much better, much faster. And then recovery is another thing where it's very important to do this the proper way. You have to make sure you wean these reptiles off the gas before the end of the procedure. So if we're doing a coelomic surgery, as soon as we start putting sutures in, I will actually discontinue the gas anesthetic and maintain them at oxygen, and I will switch them to room air right away. And the reason for that is that oxygen is the primary stimulus for breathing in reptiles. There's some CO2 receptivity there too, but oxygen is a primary stimulus. So if you keep reptiles at 100% oxygen, it's going to be very, very difficult to get them breathing again. So you have to make sure that you keep them at 100% oxygen with the gas during the surgery, but at the end, you want to drop that down to room air. If you have medical air, that's fine, but a lot of people don't have access to that. But certainly you want to bring them down to room air, just get an ambu bag and ventilate them that way, and that makes a huge, huge difference also. So for the recovery, wean them off before gas, low flow rate, not only low flow rate, but also low oxygen concentration. So you want to use room air or medical air. Keep them warm. A lot of people forget about that in the recovery period. They forget to keep them warm, and they start going downhill again. And again, remember that oxygen is that big stimulus for these guys. So in closing here, again, the keys to success, you have to keep your patients warm. That's very, very important. You have to keep that metabolism going so they can metabolize the drugs efficiently. You have to keep them well hydrated. If they're warm and their metabolism is working properly and they're well hydrated, you will metabolize your drugs. And if you metabolize your drugs, you're going to wake up a lot faster. I truly believe that that's one of the main reasons a lot of people struggle with reptile anesthesia is that these animals are not at the proper temperature, they're not hydrated well enough, and they really metabolize the drugs a lot slower. You have to make sure you're using balanced anesthesia and analgesia. That also is going to help when you're bringing the lower dosages of these anesthetics and reducing the dose of your anesthetics. Is going to reduce the side effects, and it's also going to allow for them to metabolize these drugs a little bit faster, especially things like ketamine that can be a little bit tougher to metabolize in certain species. And last but not least, you have to discontinue the oxygen before the end of the surgery. So these are the 4 tenets that I really promote quite a bit. Ever since we started doing these 4 things right here, I can tell you that the quality of our anesthetic events has improved significantly. The grand majority of the reptiles that we do true surgeries on that are truly anesthetized will start waking up before they leave the OR. And it doesn't take us longer than probably an hour after the procedure is done for those animals to be extubated and to be at a point that we consider them to be stable and be doing well on their own. Okay. Now, reptiles are inherently difficult. There's certainly some patients out there that are going to be a lot tougher. Re-narcotization, I mentioned that earlier. That's something that we're starting to see more and more of, especially in big chelonians. So keep that in mind. Sometimes if you do all these things and the patient seems to wake up and then they go back down again, they're probably going through some re-narcotization. I think there's some sort of biphasic metabolism that sometimes happens with the drugs in these patients also, and that's why some of the reptiles seem to start recovering, and then they get depressed again, and then they recover, they get depressed again, and finally come out of it. But these 4 things I think are key, and if this is something you're not doing already, I encourage you to give it a shot, and I think you'll be very pleased at the results that you'll see with that. So in closing, I want to remind everybody, not every patient needs drugs. I rarely ever anesthetize any reptile for radiographs. Very, very rarely do I do that. This is what I do most of the time. This is an alligator snapping turtle. This was about an 80-kilo snapping turtle, and she was getting a CT and radiographs. All we did was put cotton balls over her eyes and wrap her with some vet wrap. I have a little bit of vagal stimulation, not too much pressure on the eyes, but just a little bit of vagal stimulation, also blocking her view. And those animals typically do really well. Green iguanas, I do that all the time. And then in her case, we actually put her in a trash can. These rectangular trash cans work really well. They fit those animals perfectly. So we actually scanned that animal for the CT scan inside the trash can. There was no sedation, no tranquilization whatsoever. That animal was fully awake. She was comfortable because in her biology, she felt like she was a nice little hole in there. She felt relaxed. She didn't struggle through this period. She didn't move whatsoever. And then the same thing can be true for crocodilians. So again, this is a Morelletti croc here, and the eyes are bandaged. The legs are tied together to keep them from moving around, but you can do a lot of things in this animal without having to tranquilize or sedate them. You can get radiographs, you can do even a CT, you can do ultrasounds. There's a lot of things that can be done in our reptile patients that don't necessarily mean that you have to give them drugs to accomplish those results. So that's probably one of the biggest takes home is make sure that whenever you're confronted with doing something like this in a reptile patient, you have to ask yourself, do I have to actually anesthetize this patient, or can we do something with just some bandaging of the eyes and trying to calm them down a little bit? Sometimes putting them in the dark also after you do that bandage helps. Make sure there's a quiet environment around so they're not getting overly excited. And again, can we do something just on tranquilization or sedation? Remember those different levels, and then make sure you're using a balanced anesthesia, use your analgesia, and try to make sure you go with those 4 tenets. You keep them warm, you keep them well hydrated, you discontinue the oxygen early enough, and you use balanced anesthesia. And those 4 things are be very, very important to try to recover. I've gotten a lot of feedback from people back that once they start doing those things, they see a huge, huge improvement. And that temperature thing, I think sometimes a lot of people sometimes struggle with. So I think, I'm not sure if we went over between the delay early on or whatever, so I apologize for that. I think there's going to be time for questions now, so I'll stick around for that. Hopefully this was helpful and useful, and if you guys have any questions later on, you guys can feel free to send me an email also and contact me, and I'll be glad to answer through email.